Welcome again, everybody, to today's webinar on potential roles for rural ambulance services in COVID-19 vaccination. I'm going to welcome Nicole Clement to the floor to introduce today's guest speakers. Nicole?
Thank you, Kiona. Hi, everybody. Thanks for joining us today for this webinar about the potential roles for rural ambulance services in the COVID vaccination process. We have a couple of speakers. Our first is going to be Matt Zavadsky, and I'll fully introduce him here in a minute. Matt is from MedStar Mobile Healthcare in Fort Worth, Texas, and also represents the National Association of EMTs. Also, we will have a little bit later in this webinar, Sean Baird, who is the current president of the American Ambulance Association and vice president of rural services for Metro West Ambulance in Oregon. He's going to share a little bit also about what he knows is going on in the country. And then we will open it up for some updates from you all about what you know is happening in your states with COVID vaccination, and definitely leave some time at the end for questions. So for right now, introducing Matt. I see he's got his slides on the screen, so he's all ready to go. But Matt is the Chief Strategic Integration Officer for MedStar Mobile Healthcare in Fort Worth, Texas. He's helped guide the implementation and financial sustainability of numerous innovative programs with healthcare partners that have transformed MedStar fully as a mobile integrated healthcare provider. Most recently, he has led the negotiations with multiple third-party payers to change the basic economic model for EMS to better align patient, provider, and payer focus on patient-centered care as opposed to simply payment for ambulance transport. Matt is also the immediate past president of the National Association of EMTs and has a master's degree in healthcare administration with a graduate certificate in healthcare data management. Matt, bringing it over to you.
Okay, now that we've run out of time for the webinar.
You paid me heartily for that, right?
Yes, it's hopefully you take credit cards. And thank you, Nicole. It's always an honor to be with you guys, and certainly today to be joined with Sean. Sean does a great job, not only for the American Ambulance Association, but for his ambulance service in Oregon, and just does a great job. So I want to walk you through what these potential roles may be in your communities and how you might be able to work with your ambulance services and other providers in your communities, especially in the rural space. Here at MedStar in Fort Worth, we are a public entity, and since essentially the vaccine was available, we have been very heavily participating in the vaccines that we'll be describing here, and a number of different roles, but also the monoclonal antibody infusions. We'll talk a little bit about that because, again, I think the rural opportunities for ambulance services to do some of these things is phenomenal. So speaking with a little bit of experience, we have done the things that we're talking about here. So it's not just somebody that has never done it before. So one of the first questions that comes up is why EMS, why ambulance services to be part of this process? Well, today, much like the rest of the healthcare system, the EMS agencies across the country, and especially in rural areas, have really gotten new recognition. The role through the pandemic, the things they've been doing has really increased their profile, increased the community trust. They also tend to be very nimble. They adopt new practices relatively easily. They, by design, almost have to be able to change on a moment's notice and pick up the ball and run with it and do other things. And often we've heard the EMS community phrased by healthcare policy people and others as sort of the Swiss Army knife of the healthcare system, because whatever needs to be done, they can do it. And then third, one of the things that we've learned here recently across the country is that doing vaccines, especially for large groups, really requires some incident command experience. And to the extent that ambulance services are part of public safety, part of an all hazards emergency response, many of the EMS leaders and the ambulance service leaders are well-versed at incident command and managing, we often refer to as multiple casualty incidents, but multiple patient incidents, and they're really good at that, and they can set things up pretty well, so they do it well. In the rural communities, they may be one of the only healthcare resources left in some of these communities. And by default, they become sort of the steadfast provider that's available, trusted, and they've got people that are available, volunteers or paid staff, whatever. So especially in those rural areas where you may have had critical access hospital closures or just don't have a lot of healthcare capacity, most communities will have some type of an EMS presence that can be tapped in to use some of that. So let's say that you want to work with some of the providers in your states and your communities to do this. What are the steps that you sort of need to go through? First thing you need to make sure is that the medical director for that agency is on board with the EMS agency taking on this role to do vaccines. They are typically a strong influencer. They can issue medical directives, protocols to facilitate the vaccine administration. And they also are generally a trusted member of the community, and a lot of folks will understand what it is that they're trying to do in partnership with the EMS agency. So making sure that they are on board with it is going to be very, very important. Second is you need to really check with your state or local regulatory folks to make sure that it's authorized. Now, we say that because paramedics generally have the authority to be able to issue, do intramuscular injections. That's within the scope of practice. Now, in some states, emergency medical technicians may or may not have that capability. We'll talk more about that in just a minute, but just checking the box, making sure that the county authority, the state authority, regional authority, whatever it is, has given approval. Many states over the course of the last few months have made great strides in changing regulations that allow EMS, EMTs, and even others to be able to do vaccine administration. It's also not a bad idea to make sure that the ambulance agency checks with their workforce to make sure that this is something that the workforce is going to be interested in doing, want to do, because sometimes that can be a little bit persnickety if you're trying to do things that the workforce might not fully support. Also, make sure as often as possible that the public health authority in that local community is also engaged in this process. This has been, as often referred to as the public health emergency, and because of that, the public health authorities really have a key role in certainly vaccine administration and even in the MAB administrations and other public health issues. So looping them in, seeing if this is something that they want EMS to do. Is there a gap that EMS can fill? Just making sure that you're working closely in collaboration with your local health authority. And they can also be an influencer. So if you're in a state that, for example, EMTs are not authorized to do intramuscular injections, if the state folks get behind, the state ambulance associations or the EMS associations get behind it, the public health agencies get behind it, a number of other communities, you can probably help facilitate change that allows that force multiplier to occur in that local community. We talked briefly about the scope of practice issues, and generally EMTs, and you've got two types of practitioners in the quote unquote, or maybe more, in the EMS space. You could have first responders or what they sometimes refer to as emergency care attendants. They have basically maybe 40 hours of training thereabouts. Then you have emergency medical technicians who have 150 to 300 hours of training. Then you could have paramedics or advanced paramedics, critical care paramedics. But in that hierarchy, generally speaking, EMTs are not authorized to do intramuscular injections. But again, we're going to talk more about that in a second. So let's look at two scenarios here. I don't know if folks are here from Pennsylvania. We got some of this information from Page Wolfberg and Worth. They are a great legal resource and consults. And they did this as part of a webinar that we jointly did recently. And we're going to look at two states when we talk about the regulatory examples. So in Pennsylvania, there is a very specific and defined scope of practice for EMTs, paramedics, and really all of the pre-hospital or the intra-hospital, shall we say, providers. And you'll see that, you know, in this particular case, Pennsylvania does not allow EMTs to do immunizations. So again, it's very specific, state controlled. There may be some local variation, but generally not. So it may be difficult in some states to get EMTs able to do these IM injections to do the vaccines. In Texas, we are blessed for many ways. God bless Texas. But we are what's called a delegated EMS practice state. And what that means is there is no state scope of practice rules in Texas. So essentially, the local medical director is the one who decides what those EMS practitioners can do in their jurisdiction, wherever it is that they're medical director. So that makes the implementation of programs like this sometimes relatively easier, because as long as the medical director is comfortable with whoever doing these procedures, it's a local decision. They authorize it, they do the training, and there they go. So here's an example. In our community, when we started doing the vaccinations, our medical director issued a medical directive, which medical directors typically do. It's essentially a protocol that basically says, hey, here's how you do the vaccines. Here's the documentation that's going to be necessary. Here's all the things that you're going to need to do, etc. But what's interesting is when you look at this directive, it really says this directive may be used by system providers, meaning the EMS system providers, who have completed an OMD approved training program for vaccine administration. So we have paramedics, we have EMTs, and we have other types of practitioners, even folks that might not necessarily be credentialed in our system, who have received special training from our office of the medical director to be able to do vaccines. And I'll give you an example. So we have a couple of dispatchers in our system who are certified paramedics, but they are not practicing with MedStar in the field. They have never gone through credential, or they're not currently credentialed, shall we say, but they still carry state certification. Those folks wanted to be able to be vaccine administrators. So they took a quick training from the office of the medical director, and they became credentialed by the office of the medical director to do vaccines, even though they might not have treated a patient for 10 years. But vaccines can be done pretty safely, so they do issue that. So that kind of covers the scope of practice issues. Just check in your state, what is the scope of practice for EMTs, paramedics, et cetera. If you need to work with your state EMS authorities or others to try and expand that. And one of the reasons I put the speedometer there is that, the goal is to get as many people vaccinated as possible, and you need a lot of people to do that. So you're going to need more than just paramedics to do that if they can. Now, once you've gone through that process, you need to do a couple of other things. First is you need to register with either the state or the CDC, and many of the states use the CDC guidelines, as a vaccine provider. I put a hot link here, and Nicole will have this presentation, and the links for all these resources are going to be built in. They are built into this presentation, so you can just click on them and go there. But CDC actually put a playbook together for people who want to be vaccine administrators. It makes it pretty easy to walk through that process. However, one of the things that you're going to need to do, like we did here, and it's going to be very state specific, is register with the state's immunization program. That is usually a relatively simple process. Simple sometimes has a little bit of different connotation, but not terribly difficult. So we've done it for a long time. We did flu vaccines before we did COVID vaccines, so it wasn't a huge issue. One of the big things we're going to talk about is what are some of the requirements to become a vaccine administrator agency in most states. First, you need a coordinator, because the state, CDC, others need somebody to contact in the event that they need some information. You need to verify with them what are some vaccine delivery times. You've heard in the media, and we can share with you directly, that vaccine availability right now is very, very limited, and it's a little bit disconcerting. So our requests for vaccine have been filled, but filled only at a fraction of what we are requesting. And most states are experiencing that. So hopefully in the near future, as things get a little bit better in the supply pipeline, we'll have some more access to vaccine, but right now it's coming in a little bit of trickling. You need to make sure you've got the storage capacity, and depending on the vaccine that your state is issuing, you may have the Pfizer vaccine, which requires some pretty significant refrigeration. Moderna also requires some refrigeration. Perhaps vaccines that are in the pipeline for the future may not have that same refrigeration criteria. In addition to just the regular refrigeration criteria, you also have to be able to prove that you are able to maintain the vaccine at the manufacturer's recommended temperature. So that typically requires something that's called a data logger. And the data logger is something that's electronic. It continually monitors the status of refrigeration and puts the information into a shared network so that people can check and make sure the vaccine is in place. It's a bit of a process. Each state may be a little bit different, but just make sure that you know what those requirements are so you can have the ambulance agency that you're going to be working with, the EMS agency you're working with, be able to meet that criteria. And then you need to know the patient profile, because part of the application process, they're going to want to know, in most states, they've prescribed that. So you've heard the ACIP, 1A, 1B, tier 2, tier 3. You just got to make sure that you're aware of and are only vaccinating the population that is currently eligible. So in Texas, believe it or not, we are still only vaccinating 1A and 1B tiered eligible people. So frontline healthcare workers, people over 65 or with significant medical issues, and we'll be doing that probably for a while, and it still becomes a bit of an issue. This is a picture here of us staffing a vaccine clinic in partnership with our county health department. That's one of our critical care paramedics getting vaccinated. And yes, Nicole, that is me doing the vaccination. I had learned at this point that these vaccines were not intraocular. So that made Alan Snell very happy because he was the paramedic getting vaccinated. Data tracking is also crucial. Every state is going to have a process for you to enter in the vaccines that you're administering and literally by person, who got vaccinated, what's their contact information. So make sure that you're working with your state, your regional authorities, your public health authority, along with the ambulance provider that you may be working on with this, to find out what those requirements are. Sometimes you need to sign an agreement to have access. In Texas, this is called MTRAC 2. MTRAC 2 is used in multiple states across the country, and it feeds into a national database. That's how the CDC and others get the information about how many people have been vaccinated, what type of vaccine was used, what was the lot number. I will tell you that this is a very tedious process. And what we've had to do in many cases is it may take us 4 hours to administer 200, 300, 400 vaccines, but it could take 3 times that long to put this information into MTRAC or whatever system is that you're going to be using. And when we have folks over at the county site that's doing a mega site, they literally have 15, 20, 30 people that are clerical workers from the health department, in some cases temporary workers, that are taking these forms, putting it into the electronic registry. So don't underestimate the amount of time, energy, and effort that it's going to take to be part of that process. Fortunately, there's, again, a number of web resources that provide you with this information. So the CDC puts out a lot of information. Again, the hot links will be in here for the presentation. This is an example of the provider agreement that you're going to need to fill out. Now, your state will typically have their own provider agreement because most of this is administered through the states. But as you look at the CDC application, your state application will look very, very similar. In some cases, it might just be the same. The logo has been changed because they use a lot of the same process for doing that. So again, this information is there for you. There's some things that you're going to have to attest to, and just make sure that you're following or helping the ambulance provider follow that process. If you need to provide them some technical assistance, you may be able to do that. Now, let's talk briefly about payment, because we always say, gosh, if where's the funding going to come from for this? I'll share with you that the AAA, NAEMT, IAFF, IFC, a bunch of the national EMS associations are working very closely with the administration, the federal administration, the Biden administration, FEMA and others, to make sure that there's funding available for EMS agencies and others to do this type of vaccine administration. The good news is that Medicare issued guidance and put in place the fact that ambulance services can bill for and get reimbursed for COVID-19 vaccines. It takes a little bit of time and effort, but not very much. And they put out this guidance literally, I think, Sean, in November, if I remember correctly. Did a big webinar about it, told all these different types of providers that yes, you can actually apply to become a vaccine administration provider, even if normally you would not be qualified to get paid for doing vaccines. And in their example, they did list specifically ambulance services. So we did, and we actually, as part of this process, and again, the hot links are there, they actually created or required people to have the MACs, I should say, the Medicare Administrative Contractors, to have hotlines for ambulance services or others who don't normally do this to be able to call and enroll as what's referred to as a mass immunizer. So we did that. We did that knowing that the reimbursement for the vaccines is actually not terribly bad. So for the first dose of the vaccine, we can get reimbursed at about $17 per vaccine. And if you set this up properly, you could do, one provider could do literally 10 vaccines an hour, as long as they've got the administrative support and the clerical support to process the patients. The second vaccine is the second dose of the vaccine is reimbursed at about $28. The difference here is because during this process, you need to track the person that you immunized the first time to make sure that they come back for their second dose, and CMS acknowledges that there is some additional expense to doing that. So the second dose is reimbursed at a higher rate than the first dose. Now, you can't bill for the vaccine because the vaccine comes to the providers for free, but you can bill for the administration. So for us, when we get our allotments or when we're helping the county health department is billing, when we're there, we're loaning our personnel to them, they're billing for the vaccine and they're reimbursing us for the personnel. But when we do it, we get the vaccine, you get the syringe, you get the needle, you get the alcohol swabs, you literally get everything that you need to administer the vaccine except the people. So they're reimbursing you for the people, which is what these rates are based on. So it actually is relatively simple. Now, I will tell you, I tested this process. I called our Medicare administrative contractor, who in our state is Novitas. They cover many states across the country. There was a hotline that you saw on the screen earlier. I called that hotline on December 7th and was on the phone with them for a total of 51 minutes, including the 4 minutes that I was on hold waiting for the next available representative. And that representative, James, super nice guy, walked me through this process, gave them all the information that they were looking for, including my social security number and date of birth, but it's the federal government, so it must be okay to give that to them. And he would not hang up the phone until he was sure that I received this letter electronically in our email. So this letter authorizes us to be a mass immunizer and get reimbursed for doing mass immunizations. So the good news is rural EMS agencies have the capability, if there's the desire on the part of the agency, the medical director, the local public health department, the community, they can engage in this very critical role in the community, and they can get reimbursed for it. So it sort of aligns all of those incentives because, again, for a lot of rural agencies, funding becomes a significant issue. And this not only offsets the cost, but they actually, when you do a cost analysis, it might be more than a break even as they go through this process. I want to move now into the sort of the next phase, which is the monoclonal antibodies, which we'll refer to as MABs. It's sort of the abbreviation. There was just an article that was in USA Today yesterday. I guess that's kind of an oxymoron, but let's say it was in USA yesterday. And we've been doing this as well. These treatments are, when done on the right population, are amazing. Some of the studies have shown a 70% reduction in hospitalizations for high-risk patients. We've been doing this primarily so far for first responders and their immediate family members who contract the coronavirus and are symptomatic and meet some high-risk criteria. Either they have an underlying medical condition, or they have a high BMI, or they have other issues that would likely lead to them being hospitalized with the coronavirus. And I can tell you that we've done a ton of these infusions, and not one person has ended up having to be hospitalized after they received the infusion, and they generally feel better within 24 hours, in some cases less. Our mayor actually had this done in Fort Worth, and she felt better same day after receiving the infusion once she had contracted the coronavirus. So there is some good evidence here. There are two types available. One is I won't even pronounce it, but it's Blamvemavir, whatever this is called. We call it BAM for short. The other is Regeneron, and that's a little bit of a cocktail that you have to mix, but again, not a huge deal. Any paramedic who's used to doing medication infusions can do this calculation pretty easily. So it does work very, very well. The good news about the monoclonal antibody or the MAB infusions is that this is also reimbursable by Medicare for the infusion. The same registration process, we've been told the same registration process for being registered to get reimbursed for vaccines applies for MAB infusions. We have not tested that yet because, again, we've been doing so far first responders and their families, and we haven't charged for that. This is another example where you get the materials for free. So the ambulance provider that's going to do this, usually it comes through FEMA or other resources or CDC or whoever is distributing this. Sometimes it's directly by the manufacturer, but the provider does not pay for the materials. And in this case, the material being the drug specifically. You will have to provide the saline that it has to be mixed with and the IV tubing and that kind of stuff. But you'll see that the reimbursement for the MAB infusion is actually pretty decent. This is about a 3-hour process. It takes about a half an hour of prep once the patient arrives. The infusion takes an hour. Then the patient has to be monitored for an hour for any adverse reaction, and then they are free to go. So for us, it's essentially a 3-hour, it has been a 3-hour thing, but you can do multiple patients at a time in an infusion center that we've set up. We've actually started a process to use our Ambus to do this because we do multiple patients at the same time. But again, phenomenal way for a rural EMS agency to be able to treat people in their community who contract coronavirus, are symptomatic, have some risk factors that could lead to them being hospitalized, and a very simple referral process, quick screening process. Come on in, stick an IV, infuse something over an hour, watch them for an hour to make sure that they're okay, and literally they're going to feel much better and prevent hospitalization. So again, could be done in your community. We did a flash poll 2 days ago. And when we asked the flash poll, we asked the agencies who responded a few simple questions. So first one, and I think we're up to now almost 100 responses. So in this particular case, we had 87 respondents when we did this analysis yesterday, because Nicole wanted me to get this into the slide. And then of course, in true Nicole fashion, she had like 10 questions about the data. But is your agency participating in vaccines? So you can see a lot of the EMS agencies are participating in the vaccine. You can see the breakdown there. Some are staffing other clinics. A lot are doing it their own. Many are, the majority are doing both. So that's what we're doing. We send people every day to the mega center here in our county. We also do mobile vaccine clinics. We also are obviously doing our own staff and some other things. But you can see a lot of agencies are doing that. We asked them, what is your one aha moment? And again, we won't have time on the webinar to kind of go through this now, but you'll get this as a handout and you'll see what the people who are doing it said are sort of the keys to success. Notice a couple things here. You'll see repeated: work closely with your public health officials, make sure that you've got the ability to do roster billing, make sure you understand how much vaccine is available. And again, that's been our biggest issue. Every week we request 500 to 1,000 doses, and we've been getting maybe 100 every week. So it does become a bit of an issue from that supply chain. We then asked if they're getting reimbursed. And this is one of the 22 questions that Nicole had. The question here is, are you billing for it? And you'll notice that only about a quarter of the agencies are billing for the vaccine administration. And the question is, why aren't more billing for it? And I think just because it's new and it's different. I mean, let's face it, the ability to register as a mass immunizer really just sort of came out at the end of November, beginning of December. And some agencies, might not be aware of it. They may not have even the expertise to call their Medicare administrative contractor. They may not even know who that is. So if you're working with some of the providers in your state or in your area and they don't know and they need some assistance, give them our information and we are happy to help them walk through this process. It's not as difficult as you think or as difficult as they would think if somebody literally just kind of walks them through. We've had a couple of agencies who have called and said, I don't know what to do. And literally we did a conference call, and they called their MAC. We were on the call with them, and we literally just walked them through the process. And by the time we hung up the phone, they got their letter, they were good to go. So it's there and available. Then we asked the questions about MAB infusions. Obviously, not a lot of people are doing it. The federal government is setting up a lot of regional infusion centers, which is great because again, they're recognizing the value of this. But this could be an area where, especially in a rural area, you might have a rural health clinic or a physician's office, or really anywhere that they need some staffing assistance to do the infusions. One of the emergency use authorizations requirements is that it has to be in the outpatient setting. So you can't do it in a hospital, it has to be in an outpatient setting, but you have to have the immediate availability of 911 EMS that's written right into the emergency use authorization for both of these drugs, that EMS has to be immediately available. So our philosophy was, well, let's make EMS immediately available because EMS will just do the infusion and we're going to be there in case anything happens. So it certainly met the EAU. But again, I think over time, because this is going to be a several month, if not a year process, more and more agencies are going to start doing this. It's still very, very new. And notice that a lot of people are still staffing other clinics. Some are doing their own, and some are doing both. So very important. Aha moments, make sure you're aware of for infusions, make sure you're aware of the state's ordering process. A lot of skilled nursing facilities and long-term acute care facilities are doing these in their facilities because they do meet the criteria for being outpatient. And then we did a little bit of a drill down just for Nicole to see, okay, so of the respondents that we got, how many were rural? And as you could probably imagine, there weren't many that were rural. About 13% overall were either rural or frontier. But here's their breakdown. So notice that a lot of the rural agencies or agencies in rural areas are already doing some involvement with the COVID vaccine. Just make sure that you're maximizing that as much as possible. And look at that, the majority of them are doing their own. Again, probably because there might not be a lot of other resources in the community. But again, here's some of the key things that those people who are doing it said were important as you stand up these programs. Here's just a couple of quick pictures. This is actually the Fort Worth Fire Chief. This is our County Public Health Director. And they did a big push where they had the media there. And the media actually covered Chief Davis and Vinny getting vaccinated. One of our paramedics is vaccinating the fire chief. That's me vaccinating the public health director, just as a way to make sure that we are getting a message out that it's safe. We want to do it. This is one of the mobile clinics that we set up. What you can't see here is we were doing the vaccines, and here the open area of the fire station was where they were sitting for their 15 minutes that are required. This line was 2 blocks long. But of course, we were encouraging social distancing. But literally people went in this door, they got shot, they come out the back door, sit here for a few minutes, and then they were gone. And again, we processed 50 or 60 vaccines in about 4 hours. So again, can be done very well. This is an example of our folks staffing the county public health clinic. These are some of our paramedics vaccinating, because remember, we were only doing tier 1A, which were first responders and frontline healthcare workers. So these were all either firefighters or first responders that were coming in for their vaccine, and we were doing that. As we close and turn the conversation back over to the other folks that Nicole have invited, remember that earlier we had gone over some other additional roles that EMS can do in rural areas, specifically related to the coronavirus. First, we talked about doing COVID testing. We continue to do that. We have 20 to 30 people every morning that show up and do a drive-by COVID testing, doing some in-home testing. And again, generally something that's approved in your local authority by your medical director and your states. We talked about alternate dispositions. A lot of places are doing treatment in place for potentially COVID patients. We just started a program where we actually have the rapid tests for the coronavirus on our ambulances. And when the crews encounter someone who's symptomatic by both symptoms and history as potentially being COVID positive, we administer the test right there. 15 minutes later, we get the result. Based on the result, we give the patient some advice about what they should do next, including treatment in place. We do transport to alternate destinations, et cetera. Telemedicine could be another role for these rural agencies. They could either do it on a 911 call to help prevent a long distance transport to a hospital, but they could also pre-schedule things with a physician who wants to do telemedicine with their patients. And maybe the EMS agency brings the telemedicine to the patient's home, or the patient comes to the EMS station where they can set up a telemedicine visit with their distant doctor. Could be very effective and a great way for a rural EMS agency to become more involved in the coronavirus mitigation. One of the programs that we started at the request of one of our large hospital systems was a what we call observation admission avoidance program. So those patients who might need to stay in the hospital for 36, 48 hours in observation status, instead of them doing that, the hospital sends the patient home with a referral to us. We do the follow-up for about 24 to 48, sometimes 72 hours to make sure that patient's doing okay. That allows the clinical staff in the ER to feel comfortable discharging the patient, and they do their quote unquote observation at home with us checking in on them, making sure that they're doing okay. And then we talked earlier about a subscription service where you can have your rural agency that you work with be able to have people subscribe to a service on demand program where they pay a fee either annually or monthly to have the availability to have the EMS agency come out on a non-emergency basis, check on them, make sure they're doing okay. If they don't feel well, come on out on a non-emergency visit, just check and see, maybe do a telemedicine with their doc. But again, these are all things we talked about already that rural EMS agencies are well positioned for doing in their local communities. With that, I'm going to let Nicole take over and decide how she wants to transition to the other excellent speakers and then go into Q&A.
Thanks, Matt. So I think before we turn it over to Sean, there were a couple of questions in the chat. Jill from Arizona was wondering where the reimbursement is coming from. Are the health plans reimbursing that, or is that coming from the federal level?
Great question. Yes, is the answer. So Medicare is paying for it in most states under the encouragement of CMS. Medicaid is paying for it. In fact, one of the memorandums that came from CMS to the state Medicaid directors was, if you have opted to get the COVID bump in the CMS payment to your state, which I think is a 7, 8, 9% increase in Medicaid funding going to the states, we expect you to pay for vaccines and infusions. And in their quote, we are unaware of any state that has not applied for that additional funding. Commercial insurers almost always are going to pay for this. Again, roster bill, you just need to work with the agency that you're going to encourage to do this in your states, or all the agencies to work with the local payers to figure out what process they want to use. The other good news is that specifically for the MAB infusions, the uninsured can be billed for through the HRSA uninsured COVID fund and get paid for the uninsured infusions, just like they get paid for the uninsured ambulance transport for COVID positive patients. The patient has to be COVID positive in order to be eligible for that, but there is funding available for that as well. Good question.
Yeah. So did that answer Billy's question? Billy had a question about if you're getting paid for the COVID test when done by EMS. She said, and I don't know what state she's in, but they're seeing many insurances are passing the costs on to patients by deductible or copay / co-insurance.
Yeah, that's a little stickier wicket. The treatment is one thing, testing is another. Testing has been a little bit less regulated than the actual treatments and the vaccines, and the payers have a lot of flexibility to determine how they want to do that. So what we have done is, and your agencies can do the same, is if under the public health emergency, they can generally get reimbursed by FEMA under the FEMA umbrella for either giving personnel to do testing and that kind of thing. So FEMA does have the ability to pay for resources to do testing. Some of that's being used also for vaccines and MABs. We have chosen not to get funded by FEMA for that because the revenue from the billing is better than the funding from FEMA.
Yeah, I was thinking, holy cow, a $300 payment for that MAB treatment seems seems pretty good. And for those that aren't getting reimbursed for it, holy moly, it seems like the work to get reimbursed for it would be well worth it at that reimbursement rate.
Yep.
Okay, I had one question that was sent to me directly, and that question was, that person was wondering if these new EMS COVID test providers would be considered in-network providers for persons wishing to submit claims to their insurance companies or reimbursement of test costs.
I'm not sure we can answer that. It's really going to depend on the payer. You know, we've had issues with even just regular ambulance service being reimbursed at an in-network, non-network rate, et cetera. We have not done any billing for the COVID testing. We got the tests for free. And we literally just are getting reimbursed through FEMA for the time of the personnel that were doing the testing. And for the ones that we put on the ambulances, we got the tests for free from FEMA, and the crew's on scene anyway. So it's not like we've incurred any additional cost. So
Sure.
It's really just an additional assessment that we're providing without having to spend the money for putting the tests on the ambulance.
Mm-hmm. And then there was one more question about that related to volunteers. Can EMS providers, volunteer providers, can that be billed? Can that be reimbursed if it's a volunteer provider?
As long as they've got a provider number for Medicare, you bet.
Okay, great. Lots of reimbursement questions. Okay.
No margin, no mission, right, Sean?
Exactly.
And speaking of Sean, we are going to turn it over to him. I don't have a full bio for Sean, but as I said earlier, he is the current president of the American Ambulance Association and vice president of rural services for Metro West Ambulance in Oregon, and agreed to come and share some of what he knows about what's going on.
Sure. Thank you, Nicole. And thanks, Matt. That was really a very good, thorough overview of the depth and variety of the services that can be offered. Just briefly, I work out here in Oregon. We're a group of 8 companies. We serve Northern California all the way up the Oregon coast to the Southwest Washington coast. And for those of you who know our great state on the Willamette Valley and into Southern Oregon, we have a couple of companies there. So we cover a lot of rural ground. And I started on the COVID stuff right away with testing, and testing became our kind of deployment model from which we built our vaccine administration model off of. And we do a little bit different in terms of covering the cost. Our companies are for-profit companies, but I also work with a lot of small volunteer fire departments and other nonprofit entities and helping them get set up as providers around the state in Oregon as well. But we have followed a model where we are working with local public health departments as well as the state health authority, and do direct contracts for services with them to do the vaccine administration. And so then we take task orders from them to complete a particular mission. So a county in Southern Oregon, the local public health department gets its weekly vaccine allocation. They have some priorities within their tier 1A or 1B, whatever we're working on, that may have difficulty accessing the vaccine in a traditional sense. Maybe there's no regional hospital anywhere nearby that has the Pfizer vaccine. So the county gets the Moderna vaccine that's a little more mobile. And they say, hey, we've got a rural health clinic that really doesn't have capacity to receive, 10 doses for their staff. Can you guys deploy a crew out and hit those 10 folks? And these can be pretty remote. They can be a couple 100 miles from any larger medical facility. And we tend to try to lump those operationally, lump together 2 or 3 missions like that in a day trip. It may be that we only get 30 or 40 vaccines done in that day, but we're able to hit them all. And the way our contract works, we build a county either per vaccine administration, or in the more rural areas, we tend to do a per hour, per person rate. And the county pays us, so we don't have to generate invoices and bill insurance for every one of those administrations. But rather the county pays us, and then the county seeks their reimbursement through the feds for all, lumped in with all of the different COVID response related activities that county public health department is undertaking. So that's one model that we're doing. And it's been really successful for the really remote, hard to reach areas, some tribal land, some just difficult to access, where you have like a small adult foster care facility that's 60 miles from anything. But they have essential workers and residents who are at high risk, and we need to get them taken care of. That hourly rate works well for that, because if you spend half a day going to get a couple of these facilities, it's important in the public health sense, but you can't cover the cost if you're only billing for 5 shots. So that's one model. And then briefly, we also have state contracts, which are all on a per vaccine administration fee. And the state will send us a targeted, they have counties are through the EOC system. A county says its resources are exhausted, puts a request into the state calls on us, or there are other ambulance services in Oregon that are enrolled in the same system. They'll assign us a task like, go do all of the personnel at such and such facility. Here's your task order. Your vaccine is coming tomorrow at 8. You call the facility and schedule it, and we'll go do 300 administrations in a day at one facility. But again, the mobility that EMS brings to that, the flexibility, really has been, I think, of great value to our counties and our state. And one thing that I think the rural health community could do as a facilitator between that is really connecting local public health departments with their EMS provider and their state health authority to suggest these kind of models and work through the technical help that some of the smaller EMS agencies might need to do the steps that Matt thoroughly outlined at the beginning to be able to receive the vaccine. And I'm just going to do, Nicole, a quick time check with you. I guess one other thing that I would mention is we talked about the monoclonal antibody administration. While we're not, I'm not personally doing that with our company, we are doing remdesivir administration as part of our hospital at home program for COVID patients who are remaining in their home. And that reimbursement model is quite different because those are bundled payments from the health systems that we contract with. But also a good function for EMS to be starting to look into, as we're going to have continued need for patients to be treated at home over the next several months with different options.
Great examples. So I have a question for you. When you are on these missions out to rural areas to give vaccines, and you said you're lumping a couple of those missions together when possible. So these folks are all like, that you're going out there to give 10 shots and it's confirmed. You're not getting out there and starting, setting up shop and then having people not want to get it. We are hearing a lot about hesitancy in rural areas to get the vaccine. So I was just wondering if you're running into that.
That is a great point. And early on, we did run into a few situations where it put us in a real pinch to use the remaining vaccine that we had available in a timely fashion, when we would open a vial and then discover that of this scheduled 6, only 3 wanted it or whatever, What we've done is develop every event has a list of backup people that we can use up to 9 doses if we had one open and only used 1 dose, that we can access in an alternate way to get that used up. But more importantly, at the front end, we're doing repeat calls a couple of different times to the facility administrator to make sure that okay, this is the list. These are the people that have signed consent forms. And also understand you don't get to add, depending on the numbers, you're probably not going to get to add anybody. So people have to have made the commitment before we come out.
Mm-hmm. Great. So everybody else on the call, I am interested in two things. One, if you have questions for either Matt or Sean, you could definitely ask them now. But also I'm interested in hearing about what's happening in your states, if any of you have interesting things to share. I know in Minnesota, just last week, the Commissioner of Health signed an order, if you will, allowing EMTs and AEMTs, paramedics, to be able to administer the COVID vaccination. And Matt talked about that a little bit, about what is even allowed in your state before you start looking at the requirements above that. So, so that was one thing that I know about Minnesota. Nicole Brenton from Maine, I think, was going to talk a little bit about what's happening in Maine. Nicole, are you with us?
Yes. Hi, everyone. Nicole Breton from Maine. I'm the State Director for the Office of Rural Health and Primary Care. I want to just, excellent presentation, a wealth of information, and something that I'm going to bring back to my EMS partners and share within the division. So for the state of Maine, we have been working closely with all the leadership in Maine EMS, being involved in every daily discussions that we have internally, 7 days a week. EMS providers in Maine are in the phase 1A, and they have been able to do COVID vaccinations, and they are actually billing for those services right now. There's been discussions. We are still in 1A, moving into phase 1B for our older population. There's been multiple discussions about having, especially in our rural areas, having the emergency response be the front line to vaccinate, especially where people have transportation issues and are maybe more reluctant. So that I think they would feel more comfortable with someone that they're familiar with. So once we are able to get more vaccine, I will see the place of our EMS providers being able to go out and vaccinate within the community. But right now we're just having more of a hospital-based rollout.
Okay. Before we continue on with any other questions or updates, Kiona, will you pop up our slide that has announcements and upcoming events? And while she does that and puts that up, she'll also start cycling through our post-polling questions, because we're coming to an end here. But I still, if anybody else has any questions, I would encourage you to unmute your mic and go ahead and ask while we have Matt Zavadsky here and Sean. We have these two subject matter experts. I'd be happy to answer your questions. So feel free to unmute your mic and ask.
Nicole, I have a question. This is Jill.
Hi, Jill.
If the EMT folks don't have a provider identifier number, that's what they need to be able to get paid to do the vaccine, correct?
Yes and no. So it's easier if they already have a provider number, because then you add on the mass immunizer type 2, type 73, depending on the MAC, to that. Now, it's possible that they could get an express temporary enrollment. That may be a little bit outside of their comfort zone, but you may need to look at other funding options, like Sean mentioned, through a state mission assignment for using FEMA dollars for reimbursement, that kind of thing. In those cases, might be easier than them trying to get a provider number for a temporary period of time, which may be a year or so or less.
Yeah, because it takes a little while to get that NPI, right?
Yep, typically.
Yeah. Thank you.
Anybody else have questions? All right. Well, Kiona popped up the polling questions like I asked. You can kind of click and drag that to the right a little bit or the left, however your screen looks. If you want to, otherwise I'll just run quick through these upcoming events. Thank you very much, Matt, for dealing with all my many demands and as always, helping me get what I need. Sean, thank you so much. This is the first time I've had a chance to interact with you, so it's been nice to have you here as well. Upcoming events, we have Task 90 coming up on February 17th. The topic for that is going to be health equity. We have Arquita hosting MB-Quit virtual knowledge group on the 18th. I have a National Rural HIT Coalition coming up on February 19th, so that's a busy week. And then we have a telehealth webinar series that we are kicking off. You should have some information in your inboxes about this soon. Telehealth 101 will kick that off, and this is all for flex programs, which actually is a little bit different than this webinar. This webinar was about EMS for the flex programs, but also there was quite a bit of information in here that would be useful for your ambulance services. So I would definitely encourage you to share this with your EMS partners and with the EMS agencies if you have access to them. And really anybody else that's interested, the recording will be available within the next 5 days, so you can share that with them. A few other reminders, if you're interested in that one-on-one subject matter expert coaching related to flex program evaluation, that will be available through February. So reach out to us in the task inbox, task@ruralcenter.org. Building and Sustaining Partnerships Learning Collaborative. We are gathering folks that are interested in that through February 29th. There is a form to fill out to indicate your interest. And if you aren't aware of where that form is, I would say, again, contact the task inbox, task@ruralcenter.org. And one last reminder, we have a CAW recognition cycle open. So if you have critical access hospitals in your state that have demonstrated innovative approaches to collaboration through telehealth to minimize barriers by connecting rural populations to needed healthcare in order to address clinical issues and patient needs, that also is open through February 10th. And that you can find on the navigation bar on the task website, www.ruralcenter.org/task. Okay, and that is it. Thank you everybody for joining us, and feel free to contact me if you have any more questions about this, and I can reach out to Matt and Sean to make a connection as well. So thanks everybody, have a good day.
Thank you.